Hello and welcome to Veterinary Journal Club, a continuation of Vet Books. This is episode 5?
5, chapter 4.
5, chapter 4.
Plus 1.
Yeah, 4 and plus 1. So this is chapter 4. This is the follow-up to chapter 3. But chapter 3 was CPR, and this is post-cardiac arrest care. So actually same authors as the last chapter, Drs. Bowler and Fletcher, but they flip-flopped first and second author.
Oh, that's weird.
Why is that weird?
I think it's weird that they authored to just make it one chapter.
Yeah, but they're pretty distinct, actually.
Yeah.
Yeah. So yeah, I think it's important that they're separate chapters.
It's lucky there's not a pre-CPR chapter.
That's the rest of the book.
It would just be like the entire life of animals.
The rest of the book is ideally pre-CPR.
But that would be there's a course of registration called the normal animal.
Yeah.
That would be that.
Yeah.
Pre-CPR.
No, but like, I mean, I think I said this before, like the most successful CPR is the one you don't have to do. So literally everything else in the book is pre-CPR, including post-CPR. Post-CPR care is also
pre-CPR care. In one of their diagrams, there was like...
Probably.
It was like an eyeball, and it's like, make sure you don't have to do CPR.
Yeah. Oh, yeah, prevent.
Prevent.
Yeah. So, confession, I didn't exactly thoroughly read this chapter again. I'm sure I've read it at some point.
Because you've been busy, because it's been my birthday. You've been doing birthday stuff for me.
It's Topher's birthday. He turned 47.
No, I didn't turn 47.
Oh, it's just
That's
your
how
hair
old you
turned
are.
47. Ha! No.
I'm 2 times 2 times 3 times 3.
He said this, I can't tell you how many times. He's 36, and he's like, it's 2 times 2 times 3 times 3. And,
or 6 squared.
And
2 squared times 3
my husband's
squared.
a math nerd. That's it. That's the end of the statement.
It's numerology.
You're a dork.
Without the weird.
But yes, so happy birthday.
Yeah.
So we've been on mini hiatus and doing some birthday stuff, and yeah. But we're back to work, back to podcasting. But yeah, I was kind of bad, and I didn't like read this. But I mean, I shouldn't really have to like read the chapter, but I did skim it really quickly so that I'd be somewhat prepared for this. And it's nice, and it's important the way it's organized. So did you read it?
No.
Yeah, you're like, I'm not a vet. I don't have to.
I looked through it for the game.
For the game?
Mm-hmm.
Is it a new game? Or
No,
old
it's an old game.
It's an old game? Okay.
Yeah. For all the new game ideas, we need another actual expert on so that they can...
like, other than me, you mean?
Yeah.
It's like
it wouldn't be fair
Ouch.
if I did it. I mean, I don't know anything about this stuff.
Yeah. Yeah, I would just crush you in every
you'd
game we
win.
played. Well, before we get to the game, we should probably chat about the chapter. So the main thing for me is there's, the way I think about it, like 2 major components to post-arrest care. And there is whatever caused them to die in the first place, like that needs to be addressed. And sometimes it's been addressed and you're like, okay, I'm good. But most of the time there are still like that you still have to kind of address that, or at least complete.
So they don't just die again.
Exactly. Because if you don't, then they're totally going to die again. But now we also have to grapple with the new problems that arose just from the fact that you died. It turns out dying is bad for you.
Yeah.
Specifically bad for your heart and bad for your brain. Like those are the main things that take a hit that would lead you to die again. Those are also a big part of why you probably died in the first place. Even if those weren't the primary issue, those secondarily are a big part of why you die. If your brain stops working, your heart stops beating, or if you stop breathing, you die. But the heart and the brain, they get pretty sad if you don't get blood and oxygen for a little while. So there's so that's how I kind of think about it. There's what caused the animal to die in the first place. And we need to make sure we are thinking about that and addressing that. And then there's like, okay, but now those extra problems, if it wasn't bad enough before, it was because they died. But now you have new challenges. And how bad those are, in my experience, is largely related to how long they were dead for. Like which just makes sense, right? The longer you're dead,
mm-hmm.
the more time your brain and your heart go without oxygen, without perfusion, the more damage that they will sustain. So it just makes logical sense, and it's backed up by literature. But yeah, these injuries will happen in varying degrees of severity depending on each individual situation. But so this is actually an incredibly short chapter to talk about like a big topic. I mean, that was true also of CPR, but I think it's even more true of this.
Do they pick it up again later in the book, or?
No, because
Like
again, everything else in the book is like specific. You know what I mean? Like you address the specific issue. So like that's the main thing of post-arrest care is you have to do critical care and you have to address like what that patient's needs are. So this was actually one of my favorite things. They do at the beginning of all of these chapters in the small animal critical care is there's the little key points, and there are 7 key points for this chapter, and the last one is a good one. And it's critically ill survivors should be referred to veterinary critical care centers for post-cardiac arrest care, which basically, like, if you don't do this on a regular basis, you're probably not going to be able to do a very good job. And that's okay. Like that is okay. Every time you work on, train on, try to get better at something, that's time you're not spending on something else. And so if you don't do this routinely, you're probably not going to be, you should send this case to somebody who can. So like good on you for doing the CPR and getting them back, but it's time to transport that patient.
What's the time frame for something like that?
ASAP.
Yeah. I'm thinking it's like, how long does it take like an animal to go to another hospital after it got CPR?
That is a very good point. It is a very good point because what we don't have
just
are like ambulance services and things like that. And so that it absolutely has to factor in. I would say if you're out there and you're not at a critical care center and you have resuscitated a patient from CPR, and this happens, like this happens not uncommonly. Who gave him a toy to play with during our podcast?
What toy does he have? I brought all their toys out.
Is he just playing with garbage?
We've been unpacking too.
Yeah. Okay. So, but if you're not already at a critical care center, you can do CPR and bring your patients back. And this happens. So good job. But you're going to have to now figure out like, okay, now how do I keep this patient alive? And I would say step 1 is call the nearest critical care center.
Yeah.
Because what they can do is they can help advise you on like, okay, we're 2 hours away or we're 10 minutes away. Those are different plans. Like you're going to manage this differently if you're 10 minutes away versus 2 hours. And so, but we can probably give you some advice over the phone on what are some things that you can do in the meantime. What are some things we can do to try to make transport, more successful, less likely to, precipitate for the arrest. But it's risky. Like at the end of the day, this is a risk, transporting this patient. And so the clients should know that. But not doing that is also risky.
Right.
So, you need a 24-hour facility at a minimum. Ideally, you should have a place with critical care, meaning a board-certified critical care specialist. That's why we exist, is for these. This is our time, And if that's not available, then again, a 24-hour facility with somebody who does this, even if they're not board certified, is going to be like the next level down. But if you don't have a 24-hour facility, like this animal's going to die, and there's a good chance it's going to die anyway. Like the majority of the patients that die and we get return of spontaneous circulation are going to rearrest. It's one of the things that I harp on is that how do you define like a successful CPR? And ultimately, I only consider it successful if the patient was discharged alive, to the owners.
What are the cases where it's like CPR will work and the animal will be like
when they have a
very
problem.
Good chance? Well, like the things that cause them to arrest but aren't like problems that will persist. It's just like it's
flea anemia.
Yeah.
Like, you have like a young puppy or kitten or like a cat that just is riddled with fleas and the owners didn't know it was an outdoor animal or it got outside and it's been like roaming the streets for a while and it comes in and it's super duper anemic. Well, guess what? I can give a transfusion and I can treat the fleas. Like those are treatable problems. So I can fix very quickly the anemia. Right. I can give blood products and I can give them, boom, I can slam them in and then I can treat fleas.
And they rest just because they're anemic. They're so anemic.
Yeah. Because that's what carries the oxygen in your blood. And if you don't have oxygen carrying capacity, even if your blood flow is good, it's useless, right? It's empty blood essentially. And so I can replace the oxygen carrying capacity like that, like in a matter of minutes. And so those are some of the cases that are really successful, or if they're anemic, or if they've had blood loss and I can stop the bleeding, right? So that's like treating the fleas and stopping the bleeding. So if I can tie off a bleeder, those can do really well. If they have pleural space disease, so if they have fluid or air in the space around their lungs, that's something I can treat very quickly.
And it's just causing like too much pressure so that you can't get enough flow.
It's a change in pressure so that the lungs can't expand because there's pressure around them, preventing them from expanding. And so, I can relieve that. I can relieve that very quickly. Pericardial effusion would be, now, depending on what the underlying cause of the effusion was, their long-term prognosis, if it's cancer, something like that, but it could be a treatable cancer. If it's a ruptured bulla causing a pneumothorax or trauma or something like that, I can fix those tissues, or I can get help from like a fancy surgeon or something like that. Like, there is a fixable problem. So there's a short-term solution and then potentially a long-term solution. Those are the ones that can do really well. So I like to say if they have a treatable condition or a fixable disease, general anesthesia is a fixable disease. It's like you were poisoning them and then you can stop poisoning them.
That was the one I was looking for.
Yeah. So anesthetic related deaths, assuming this was like an elective procedure, right? Not the animal that was like almost dead and we're like, it's probably going to die under anesthesia, but if we don't do this procedure, it's going to die anyway. So you try it and that one dies. Like, the prognosis for that one's still pretty terrible. But the one that goes in for an elective procedure, a dental procedure, a spay, maybe a lumpectomy, but was otherwise stable and dies related to the anesthesia, those ones also have a pretty good chance of coming back. So they need an immediately fixable or at least improvable problem in order for this to likely be successful. So it's also about like case selection, right? Who should you be doing CPR on? And I have lots of conversations and I have lots of thoughts about that. But like, if you have a patient in your ICU and you are doing everything you can to keep that animal from dying, and despite your best efforts, it dies anyway, I'm like, I wasn't holding anything back. Like, now I have that same problem that I wasn't successfully able to prevent the dying. Now I've added heart problems, brain problems on top of it. Like, I've just made this even harder. And so in those cases, like, I just have a very different conversation with the client about, goals and expectations.
It seemed like that sort of thing in an established client you'd have ahead of time.
So yes,
you kind of know what they want.
That's super duper important, because
when they walk through the door, you don't know, but
no, not necessarily. But early on, if you have an inkling that patient is going to die, you should definitely have that conversation. And for me, any patient that is hospitalized, we should have the conversation. How much kind of depth I go into it is probably going to depend a little bit on the client and a little bit on the patient. How likely or not do I think it is that it's going to die? But I think what happens is we talk about the CPR, but we don't talk about the post-arrest care. Like, we don't actually have the conversation that, by the way, if your dog dies for any reason, even if it was unexpected and anesthetic related, he's now even worse shape, and this is going to get complicated and expensive. And, by doing the CPR, you're sort of committing to that now we're going to continue. Not that you can't then choose to humanely euthanize, but there are fewer disappointing things for me than to do CPR successfully, get that patient back, have the conversation with the owner, and then euthanize. It's like,
when do you have the conversation with the owner? Because it seems like you're very busy. Like, you just did CPR and you brought it back, and now you got to do all the things to keep it alive. Yeah. When do you have time to call somebody?
You don't have time, but you have to do it. Yeah. Like, you just have to do it. So
you almost need to be like, hey Siri, call the clients.
Yeah, that should go really well.
And then you can talk on your earbuds while you're doing stuff.
3 recordings, and I just push play and be like, all right, I'm going to need you to listen to me for the next 10 minutes. And then I just push play, and then I go back to work, and then I come back and I'm like, okay, what questions do you have? It works really well. No, I don't advise that. That's a terrible plan. I was just kidding. But what I do think is really important is to have the conversation before the animal ever dies, whenever possible. Sometimes we don't have that choice because they come in on emergency and like boom, 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 it just happens. But if we have the opportunity to talk with them about what that would mean if their pet were to arrest, if their pet were to die, and we were to do CPR, what does that mean? What is that going to look like? What are the costs associated, or the likely costs associated with that? What is the prognosis associated with that? And to try and have that conversation beforehand. Again, if it's a situation where I think it's really unlikely, I tell the client, like, hey, I think it's really unlikely that while Rosie is staying here with us, that, this is going to happen. But it still can happen unexpectedly. Things can change. She's here because we don't have all the information. As we gather information, that could change. And so we need to have this conversation now. We need to have this advanced directive. And then I'm going to probably take the chance, if it's very unlikely that Rosie is going to die, and not have like a 10, 15 minute conversation about it at that time. I'm going to take the chance. And then if it happens, I'm going to have a longer conversation with them later, versus if I'm like, Rosie's most likely going to arrest, like we're going to do everything we can, but there's a good chance this dog's going to die. We're going to have the conversation now. And I'm going to talk to them now and try to make sure they understand, one, that this is likely to happen. Two, that there's a good chance it won't be successful. Three, if it is successful, what does that mean? And what are the odds that we are ultimately successful? Meaning like we get her back, and then we get her through the next stages. And sometimes it's like, hey, I think those chances are...
That's a pretty sad conversation.
It totally is. And that's why people don't like to have it.
Yeah.
Like it is. It's kind of a bummer. But it's our job, is to have that conversation.
I was just thinking, like TV CPRs.
They're super accurate.
But I think the biggest indicator on whether a TV CPR is successful or not is if the patient is already in the hospital, it's probably not going to work. But if they're just like rushed through the door real fast and they do everything, it's going to be successful.
Here's what I think is the bigger determining factor on whether CPR will be successful on television. Do you know the character's name?
Yeah, but there's that one guy from Grey's Anatomy who just always screwed up.
I don't know which guy.
The one who failed the boards.
I don't think I watched enough of it.
He was in the first seasons. He's
right.
He was the one that...
He's the jerky guy?
Yeah, the jerky guy.
Yeah, I don't remember his name.
The one who killed a couple people.
He did. I don't really remember that. Like he killed them because he was bad at CPR, or like he killed them?
He killed them because he wrote something down wrong and the nurses didn't catch it.
And things like that. Okay.
Yeah.
And so they died.
I think he killed Booger.
Who's Booger?
From Nerds.
Oh.
I'm pretty sure.
Okay. I can't remember that actor's
name. He gave him too much
name.
of something and it
oh no,
super dehydrated him.
Too much furosemide?
Like, maybe. And he was like drinking out of the toilet and then he just died.
Yikes. It
was like
know.
a 10 or 100 fold.
What were we talking about at the beginning of this? Crazy?
CPR.
Oh, okay. No, and TV. If it's a guest actor, then it could go either way. There's a good chance that patient. But if it's like if their name is in the opening segment every week, CPR is going to be successful. Mm-hmm. Maybe it goes down a little bit if it's a season finale.
Yeah.
There's like probably an algorithm.
The more of an emergency it is, the more successful.
But that's actually that's fairly reflective of real life. I would say that's generally going to be true in real life.
Because that's more probably related to blood loss and stuff.
Well, it's more related to if you just arrive with a problem that's bad enough that you could die, but we also haven't had a chance to treat you for that life-threatening condition, versus if you're in the hospital, by definition, we are treating you and trying to keep you from dying. That's kind of what I was saying before. If you're in the hospital, you're in the ICU, and I'm doing everything I can to keep you from dying, and you die anyway, I'm out of things to do. Versus if you come in off the street having just had major trauma, or it's like an initial diagnosis of a new problem, that means there's this whole plethora of things I haven't yet done that might help you.
Yeah.
And so those are the ones that I actually, so if that's been your impression on TV, I would say that's probably fairly true. If they come in on emergency, there's a better chance that there's things that can still be done, versus if they're already hospitalized, you're doing all the things that can be done, hopefully. And if not, why aren't you doing those things? So, I mean, I always kind of say I'm not holding anything back. There's not like this magic treatment that it's in my back pocket. Then I'm like, oh, well, if you're going to go ahead and die on me, I guess we'll give you that. Like, you only give it to patients give it to them now. So that's actually, I would say, a fairly accurate reflection, at least from my experience, that if it's a just arrived at the hospital arrest, because then you have to take like out of hospital arrest versus in hospital arrest. And out of hospital arrest in veterinary medicine is probably going to be terrible. Despite what clients will tell you, how when like they did CPR and everything went great. Yeah. Like when clients do CPR, it has an incredibly high success rate. But I think that probably has more to do with a misdiagnosis of they misdiagnosed cardiopulmonary arrest.
It wasn't that you gave your dog CPR, it's you broke its ribs.
Yeah, it's that it had a syncopal event. It fainted. And you're like, and so you punch on its chest and it popped up and you're like, I saved it. And you're like, you did. Good job. Well done, you. I mean, there's no harm in just being like, yeah, for sure. But also here's some training on CPR so that next time you have an even better chance. But in human medicine, like people get trained on, being first responders, or not first responders, but I guess that's what you are, you're a first responder. But I don't mean like as a career. You can go and do CPR training. You can get CPR certified, first aid certified. So that's far more common in human medicine. But not only that, we have ambulances that will come to you, and then they could be starting the resuscitation on the way to the hospital, where those are not routinely options for us in veterinary medicine. So out of hospital arrest, the other thing with out of hospital arrest is what's the underlying cause. And in people, myocardial infarctions and heart disease are a common cause. And so you see like automated external defibrillators everywhere. And if that's the reason you arrested and somebody can like defibrillate you really quickly, your odds go up. And so it gets a little more complicated, and it's not really comparing apples to apples to look at human in and out of hospital CPR versus veterinary.
Yeah, well, because people get a lot older than animals do relative to their like ideal age.
I'm not even sure that's necessarily part of it, but it's more, I think it's just like the infrastructure that's in place is probably going to be better. Like, I don't know. That might be some of it, but yeah, I think it's largely due to infrastructure and like how many bystanders are around and who know how to provide some type of life-saving first aid or CPR, versus in veterinary medicine, that's probably less frequent. And now you have to get to the nearest facility. You have to know where that is. You can't just call 911 and have an ambulance show up to your house.
It's also hard to flag someone down when you're a dog and you're having a heart attack. It's like, hey, my arms feel funny.
Right.
I think I'm going to have a heart attack. Could someone...
Yeah.
Could someone help me here?
Just recognizing that there's a problem is potentially an issue.
You just do that just in barks.
Yeah, if you ever hear that bark, it's probably that you're... Also, dogs don't really have heart attacks. I mean, they can, but they don't. Yeah, so I guess, we've just kind of gone off on this and didn't really focus on the chapter itself.
Well, get back on track.
I'm trying to. So, so they break this down into the post-cardiac arrest syndrome. So they have 4 different categories. The persistent precipitation of the pathology. So that's, say that a dozen times.
That was alliteration there.
It was pretty alliterative. That's basically what I was talking about. What's the reason they died, right? So like whatever caused them to die in the first place, don't forget about that. And then you now have new issues. So that's going to be the heart is now unhappy and you're going to have dysfunction from that. So you might have like almost a DCM-like syndrome, a dilated cardiomyopathy, where the heart muscles just aren't working very well. That can happen from myocardial stunning. Did our recording just stop? It did. All right. Well, if you're watching this on YouTube, sorry. I guess you don't know about it. Maybe we won't put this one up on YouTube.
Yeah.
All right. Sorry, YouTubers. You're just going to have to listen to the podcast. That's such a sad sound. So the heart's going to be very sad. It's not going to work optimally, which is a bummer because you really need it to. So you're going to need to try to think about ways to support that. You don't have to think about it. A lot of them are in the chapter and plenty of other resources for you. The brain has also suffered injury by not having oxygen and glucose for a while. So it gets pretty unhappy. The good news is on this one for me is that in our patients, one, they're fairly resilient neurologically. And I don't know, I suspect that's twofold. I suspect that they're partly just resilient neurologically, but I also think it's that the bar that we've set for what they need to have good neurologic function is far lower than for a person, right? Like for you, if you were to die and have CPR and come back, like neurologic dysfunction, meaning, oh, well, you can't speak, you can't read, you can't drive, you can't do all like that impacts your quality of life. Mm-hmm. But you're like, oh, but you can eat, drink, pee, poop, and sleep. And like walk around. And if that was enough for you, you'd be like, cool. And for our patients, sometimes we're like, cool. The cat pees and poops in the litter box. Yeah, exactly. He sits on the couch and watches TV with me. We watch reruns of
Friends.
I was going to say Grey's Anatomy or Friends. That's pretty popular too. So I think is your dog unable to read from now on? Okay. Like that part of its brain is gone. Yeah. Didn't notice. So some of it, I'm usually fairly optimistic about the neurologic recovery in these patients. I always warn people, like, there's a chance that, some of these neurologic functions won't ever come back. But I've had pretty good success with the neurologic recovery in post-arrest cases. And then there's the ischemia reperfusion response. And so this is where it gets complicated. Lots of things that could be going on, but this is where they have this systemic inflammatory response. So basically every tissue in the body is now going to be like, hey, we went for a while without any blood flow, and now we're getting blood flow. And this can lead to a variety of issues, from oxidative damage, from reactive oxygen species and damage to tissues that way. It can lead to disruptions in hemostasis, disruptions in just vascular tone. Yeah, I mean, there's just a lot of systemic, specific things that can be going wrong, and it's hard to address all of these things. So, pick out what do I think is going on.
And how long does the heart being stopped?
What do you mean?
Like when you start to see this stuff, what's the time scale where things get worse and worse? Is it seconds, minutes?
Probably minutes.
Tens of minutes.
Minutes, and then the longer the heart is, seconds, no, but minutes, yes, this is all going to become a problem after a few minutes. And then the more minutes.
So a few, you think 2 minutes?
2 to 3 minutes, that patient's probably going to recover pretty quickly.
Okay.
5 to 10 minutes, it's going to take longer. Longer than 10 to 15 minutes, then I start to get
And why
more
is
worried.
why does that short amount of time, does everything just kind of start to
well, you think about
up, or?
I guess the way I think about it is individual cells can go for a little while without.
Right. But I think
oxygen.
they'd be able to last more than 5 minutes.
I mean, a lot of them can, but not all of them. It's probably just numbers, right? How many cells have died and need to be recovered. And then how many of them didn't die, but are damaged, or they're now injured. So it's probably more statistical than it. I don't really know.
Yeah.
The answer
Well, I
to
guess
this
when I think of it
specifically.
as a machine, if you think of the body as a machine, it's why does it deteriorate so fast?
Right. But I guess the way I think of it, the body isn't quite, if you think about it as a machine that has an on-off switch, that I suppose that could make sense. But this is a machine that is made up of thousands and thousands of tiny machines that each have their own on-off switch, and some of them have permanently turned off the off switch, and some of them are malfunctioning, but they're they have the chance to recover. But it's all the individual cells collectively that make up a
so it's
being.
kind of cell damage that.
Yeah.
That's the thing.
Exactly. And so it's
not
how much, how many of your individual cells have
it's not
died.
That your blood just clotted from not flowing.
Right.
It's not.
I mean, there could be some of that, but no, that's not really the issue.
Yeah. It's not your veins get funny from being collapsed or something.
Not from being collapsed, but the cells that make up the walls of those vessels were not getting what they needed for a while. And again, so all of the cells in your body have varying degrees of needs. And so some, your heart and your brain, are constantly needing nutrients and oxygen. You need to come get rid of the waste. Imagine you had, every day, multiple times a day, garbage collection that. You're in either a super fancy neighborhood or just a high garbage producing area, and you need to pick up garbage all the time. That's kind of what your heart and your brain are. You need somebody to bring in supplies and get rid of waste constantly. And in an area where you're constantly making more waste and consuming more nutrients, it will take less time for the garbage to build up and for you to deplete your supplies versus we only need to have our garbage picked up once every couple of months. And we have, we don't eat a whole lot. We don't have a whole lot of demands. And so we can go for a lot longer before, if we miss a month for the garbage, we're okay. Not that big of a deal.
Yeah.
So it's kind of it's a little bit of supply and demand, and not all of your cells are equal in what they need supply wise and what they need garbage collection wise. So the higher their needs, the needier, the more high maintenance those tissues are, the more damage they're going to suffer. And where does that scale tip over into death versus life? That's hard to quantify, but you'll know it if you've tipped over into the other side. This is more high level philosophical kind of looking at it, the nitty gritty of these things. They go to into some, somewhat detail on some specific issues that can arise. just kind of looking over this, they'll talk about, issues with being able to maintain blood sugar could be a problem. Adrenal dysfunction could be a problem. Oxygenation, things like that can be a problem. Some important things to note for this is when you are, recovering a patient or managing a patient in the post-arrest period, that you can get too much of a good thing. So if like a little bit of oxygen is good, then all of the oxygen is better, right? Well, no, that's not necessarily true. So just kind of being mindful of that. I don't know. We can go into more detail, or we can kind of keep it this 20,000 foot view. What do you think?
Yeah, you think you're good?
I think so. I think everybody knows how to do this.
Motor knows that the camera's not working.
Yeah, what a little stinker. So yeah, since the camera died, Motor's like, oh, I'm going to come hang out with you guys. I don't know how he knows. It's a spelling bee.
Spelling bee.
It took me a second. I was like, it's a buzzing. It's okay. I'm going to close the book so I can't cheat.
All right.
Since they can't see me anymore. Spelling bee.
Spelling bee. I got to pull
I forgot for a second. The Motor can't hear that.
Oh, yeah.
I was like, oh, is he listening? Oh, he's not.
All right.
We've got our ear.
You have
in.
5 words.
5 words. Okay.
All right.
I did pretty good last
Make
time.
sure my buttons are up.
Let's see.
All right. Your first word is ischemia.
Ischemia. ISCHEMIA. Ischemia.
Sorry, do that again. I accidentally pushed the button.
Oh, okay. ISCHEMIA. Ischemia. Ding, ding.
That's right. All right. Your second word, which we didn't mention. Well, maybe you did mention it, is myocardial.
Myocardial. MYOCARDIAL. Myocardial.
That's correct. Your fourth word.
What? You went out of order. We only did 2.
Third word.
Okay.
Is assessment.
Ooh, a lot of S's in this one. Assessment. ASSESSMENT.
Yep.
Assessment. Okay.
Your fourth word.
Yeah.
Is glycemic.
Glycemic. GLYCEMIC. Glycemic.
And
okay, what is this one going to be?
Your last word, the hard one, is you can just do the last name. But if you get the last name, you have to spell the first name too.
What?
Is Frederick Mass. In 1891, he's the first documented chest compressions done on a human.
Mass?
Yeah.
Can I do Frederick?
Yeah, you can try Frederick first.
Oh, wait. Oh, I think, is he Frederic? FREDERIC? No?
Nope.
Are you sure it's Frederick?
I mean,
Does it spell it with a PH?
no.
Okay, Mass, is it just MASS?
No.
Okay, I don't know at all. What's that proper noun name? So Frederick Mass. Okay, what is it?
Frederick is FRIEDRIC.
Friedrich.
Yeah.
It's German.
Yeah.
Friedrich. Well, that's not fair. You said Frederick.
Yeah, whatever.
All right.
And you should know who this is. He's an important man from history. He's the first man to do chest compressions in 1891.
And how long has he been dead?
I don't know. He's probably still alive because he did chest compressions.
And his last name?
Is MAASS.
Moss. Oh, it's 2 A's and 2 S's?
Yeah.
I would have never gotten that. Do I have to give all the money back?
Huh?
I have to give all the money back?
No, that's the Price is Right. You get whatever you win.
Oh, okay, cool. 4 out of 5. I get a B.
Pretty good.
Minus. I thought you were going to give me, I don't know, arrhythmia or something.
I figure you knew how to spell all the words in this one, so I got to find. You know how to spell all the doctor stuff because you have to do.
I do have to write them.
Your discharges and stuff. You actually write your discharges.
I do.
Unlike some doctors.
Yeah. No, I do. And like I said before, I'm a pretty good speller about things, but there's assessment for a second there. I was like, I'm pretty sure it's 2 S's and 2 S's, but I was like, oh,
right. That one's tricky, even though it's probably the most common word. Everybody knows
I say it all the time, but the other thing too, for me, when I'm spelling things is if I see it and it's wrong, I'm like, wait, that looks wrong. And I recognize if it's wrong, even if I'm not sure why, but at any rate, all right. Well, that was pretty good. You're good at finding random names. Such a cheater for spelling. You're going to have to come up. But the one you did last time was a real word, but I'd never even heard of it. So
you remember what it was?
Not even a little bit.
You don't remember logorrheic?
Oh, yeah, logorrheic.
Yeah.
What did it mean again?
It's when you're talking on these things and you just keep droning on and on.
Oh, yeah, you're using it to describe me.
Yeah.
I'm never going to remember that. I refuse to remember that word.
That's too bad.
Okay, well, sorry if you wanted to watch this one. We will figure
I'll have it on YouTube. I'll just put a still frame.
Oh, okay. We'll pick a good one.
Yeah.
We'll get a cute picture of the cats and put it up there.
Okay.
Okay. We will. Oh, wait. What's the next chapter?
Yeah.
Hang on. So next time it will be. Drum roll. What did we do already?
We did.
That was chapter 4. So now we're going to do pre-arrest care. It's actually the chapter 5 is called shock, which I would consider pre-arrest care. Mm-hmm. So we'll catch you next time for Shock with Doctors De La Fourcade and Silverstein. Bye.